they just changed the time, and that 11 would have been 8 at my place. That was why, you know.
I hadn't even noticed that, but I'm glad it wasn't correct because I would have definitely not been there.
Yeah. So what I thought, if there are no questions in between, if there are questions in between, it's probably okay for you if we
Yeah.
respond right away, and if not, I would just ask some general questions regarding relevant anatomy exams, something like that, trick movements, um, something like that.
Yeah, I think that sounds great. I can, invite anybody to ask questions along the way if they want to, and we certainly can go on tangents or take it in any direction that anybody wants to. That's perfectly fine with me. So,
Perfect. So you're in the in the poorer situation. It's very early.
yeah, it's 4 a.m. here, so we're gonna do it though. It's all right.
So what I do not know if the others that are already on board are already listening, or because it does not look like we're in a chat room here.
Yeah, no, I think we're on right now. So
Yeah. Okay.
I won't kind of monitor the chat though, the text chat in this, Thomas, if you can do that. If there are questions, just stop
Sure.
and
Sure.
yeah.
I just have to see. Um, okay. Okay. Yeah. So I think we started 3 minutes right on time.
Yeah, that sounds great.
Hello?
Yes. All right.
Yes.
Hello,
Are we
everybody.
starting?
Wherever you are, it is my pleasure to welcome you to another Peripheral Nerve edition of the WFNS Rhoton Anatomy Day. My name is Thomas Gretschmann. I'm a neuro and nerve surgeon based in Klagenfurt, Austria. It is my distinct pleasure to welcome and introduce our speaker, Dr. Thomas Wilson. He is the co-director of the Center for Peripheral Nerve Surgery and the associate program director of the neurosurgery residency at the Stanford University. Dr. Wilson is originally from Omaha, Nebraska, finished his med school at the University of Nebraska, followed by a residency at the University of Michigan, where he was mentored under Dr. Linda Yang. This was followed by a fellowship in nerve surgery under Dr. Robert Sprinner at the Mayo Clinic. Today, we'll cover the relevant anatomy of the radial nerve, and the audience is yours, Dr. Wilson.
Thanks for the introduction, Thomas. It's a pleasure to be here with everybody. I think that we can format this very informally today. So, if anybody does have questions, please stop as we go. There'll be time at the end if people would like to ask questions as well. But we can take this on tangents if people want. I'm happy to talk about anything that people want to talk about today. So I have an outline of the presentation, but certainly please feel free to stop and ask questions at any point. Chime in verbally, just turn your mics on and chime in verbally if you want, or if you're more comfortable putting it into a text chat, that's perfectly fine too. So we're going to talk about the radial nerve, and we'll start with just an overview of the radial nerve, and then I'm going to break it down into kind of individually relevant segments of the radial nerve as it pertains to nerve surgery and typical exposures that we might do for the radial nerve. So the radial nerve, as you probably all know, derives from all 5 of the nerve roots of the brachial plexus. It's one of the terminal branches of the posterior cord, but being a posterior cord branch, C5, C6, C7, C8, T1 all contribute to that through the posterior divisions of the trunks. So the radial nerve anatomy is complicated in that sense, given that it really involves all of the nerve roots. And that becomes relevant as we think about ways of doing nerve transfers, particularly in spinal cord injury situations and those types of things. So the radial nerve, at its origin around the axilla, then almost immediately gives off the triceps branches. So the triceps branches on the radial nerve are very, very proximal. And then above the elbow, it continues wrapping around the spiral groove of the humerus and eventually gives off the posterior cutaneous nerve of the arm, the posterior cutaneous nerve of the forearm, brachioradialis branch, and extensor carpi radialis longus branches above the elbow, and then continues distal to the elbow, dividing into its 2 major terminal branches, which are the superficial radial nerve and the posterior interosseous nerve. There's some alternative nomenclature for the posterior interosseous nerve. Some people will term the initial part of that the deep radial nerve versus the posterior interosseous nerve. And the terminology, at least from my perspective, seems quite variable about when those 2 terms are used and where exactly they're defined. So don't be confused by that if you see those alternative terminologies in some of, especially the anatomical texts. As the radial nerve comes distal to the elbow, it's going to give off its major sensory terminal branch, which is the superficial radial nerve that supplies the dorsal hand and distal wrist on the lateral side, including the dorsal aspect of the thumb, typically the dorsal aspect of the index and middle finger. And then its major motor branch is the posterior interosseous nerve or deep radial nerve, which we'll talk about in some more detail. The sensory distribution of the radial nerve overall is primarily from three major sensory branches, which are the posterior cutaneous nerve of the arm, or posterior brachial cutaneous nerve, the posterior cutaneous nerve of the forearm, or posterior antebrachial cutaneous nerve, and then that superficial radial branch that we just looked at. So all in total, most of the posterior arm, posterior forearm, and then that dorsal lateral hand are all supplied by radial nerve branches for the cutaneous sensation. When we think about the individual muscles of the radial nerve, this has become more relevant, again, in the context of thinking about how we do nerve transfers for patients with spinal cord injuries. It's important or increasingly relevant to understand which nerve roots are contributing to which muscles. And so when this is not an exhaustive list of all of the radial nerve innervated muscles, but this is roughly speaking what the major contributors to each of the major muscle groups are. Triceps being C6, C7, and C8. C7 is typically listed as the dominant innervation to the triceps, though, as you know, many of us know, if you do a C7 contralateral C7 nerve transfer and cut the entire C7 root, you actually very rarely end up with triceps weakness. So even though it is a major contributor, there's quite significant contributions from both C6 and C8. Particularly relevant is the supinator. That's become a very common donor nerve in the context of spinal cord injuries. And it's a C5, C6 innervated muscle, as well as the brachioradialis. We then go to C6 and C7 for the wrist extensors. And then it's predominantly C7 and even more C8 for the finger extensors, including the thumb extensor. So in mid-cervical injuries, the supinator tends to be still working, whereas the wrist and finger extensors, especially the finger extensors, tend to be part of the injury pattern. And so that's where it becomes particularly relevant, is thinking about nerve transfers where the supinator may still be working, and we need to try to restore finger extension. The most common radial nerve injury, though, is in association with humerus fractures. So the radial nerve is very intimately associated with the humerus as it wraps around the spiral groove. So mid-humeral shaft fractures, a very common injury pattern would be an injury to the radial nerve in that location. And that can happen either related to the fracture itself with either stretch or even laceration from sharp bony edges. That can happen from fracture reduction, where the radial nerve gets caught in the reduced fracture. And that can also happen iatrogenically when our orthopedic surgery colleagues are plating the humerus fracture. The poor radial nerve can sometimes end up under the plate, like in the picture shown here. So this would probably be the most common thing that we're going to see as far as radial nerve injuries go. But there's a variety of other radial nerve injuries or injuries to branches that we see a little bit less commonly. So when we think about the branches of the radial nerve, these can be very useful in thinking about what the injury patterns or the patient presentations will look like when you see these various injuries. So when we start from very proximal, the triceps branches come off of the radial nerve extremely proximally up in the axilla, almost at the origin of the radial nerve. It's fairly difficult actually to get a proximal enough radial nerve injury that you also don't have some involvement of the other posterior cord branches, including the axillary nerve. Not impossible, but it's relatively rare. So if there's involvement of the triceps, you automatically have to put the injury very, very proximally along the radial nerve. The triceps branches then come off, and all of the rest of the branches, muscular branches, are distal to where the nerve is typically wrapping around the spiral groove. And so the most common injury, where we see that injury to the radial nerve in association with humerus fractures, will spare the triceps, but will involve all the rest of the distal nerve. The very first branch after the fracture typically is the brachioradialis branch. Then we get the wrist extensors and then the finger extensors. So the mid-humeral shaft fractures and the injury in that location will typically have a complete wrist drop and a complete finger drop. As we come more distally, the next major branches then are the posterior interosseous nerve. And the posterior interosseous nerve occurs or arises distal to where the extensor carpi radialis longus branch is at. And so an injury that is specific to the posterior interosseous nerve will spare that nerve branch to the extensor carpi radialis longus. And so because of that, the wrist extension will be weakened but preserved. The extensor carpi ulnaris is lost when a posterior interosseous nerve injury occurs. And as a result of that, you will see the radial deviation of the wrist in wrist extension. The radial wrist extensors work, and the ulnar wrist extensors do not. And so you get radial deviation of the wrist and a complete finger drop. So it's a finger drop without a wrist drop with radial deviation. That's the pattern that you would see for a posterior interosseous nerve injury, which is represented in that bottom pane on the right-hand side of your screen. Okay, so let's take segments now of the nerve and talk about the kind of dive into each of them and talk about the relevant anatomy and where we might encounter this particular anatomy for specific operations. So the first place that I'm going to talk about is at the triangular interval, where the radial nerve has wrapped around the humerus and now is kind of emerging as it's coming around the humerus on the posterior lateral aspect. So common operations that we might use this kind of an exposure for would be radial nerve triceps branch to axillary nerve transfer. In spinal cord injury, we've started doing posterior division of axillary nerve or teres minor branch to triceps branch nerve transfer, and then any radial nerve tumors that might be near the triangular interval. So as we think about this anatomy, kind of think about it in the context of those common operations. So this is what the anatomy looks like. The triangular interval where the radial nerve emerges from is separated from the quadrangular space or quadrilateral space by the teres major muscle. The quadrangular space or quadrilateral space is where the axillary nerve is going to emerge from, and then the triangular interval is where the radial nerve will emerge from, with the triangular interval being defined by the lateral head of the triceps, long head of the triceps, and the teres major, or some will define that actually as the humerus as opposed to the lateral head of the triceps on one side. When the radial nerve emerges from the triangular interval, it is going to essentially dive underneath the lateral head of the triceps and be sitting on the surface of the medial head of the triceps as it's traversing that space in that location. And so that's the anatomy that we're going to have to be aware of if we want to expose the radial nerve as we come more distally. So this is the typical exposure that I would use for this. Everybody, I think, does this a little bit differently. I tend to, unless I need to get very posteriorly, do this actually in the supine position with the arm draped across the body to expose the posterior lateral arm. This can certainly be done in the prone position as well. But this incision line is targeting the posterior aspect of the deltoid to find the interval between where the deltoid and the triceps are at, and then following longitudinally down the arm, with the idea being that we're going to find where the radial nerve is coursing between the two triceps heads that we saw in the previous image. So as we make that incision and dissect down, especially if we're trying to expose the axillary nerve, this is an intraoperative picture. One of the first things that you'll often find is which I don't have actually pictured very well here, but it's in this white loop. This is the cutaneous branch of the axillary nerve, so the superior lateral cutaneous branch. That is oftentimes the first thing that is encountered and can be a very good guide for the dissection, which will take you down into the quadrangular space. So this is the axillary nerve emerging from the quadrangular space. This is the teres major muscle. So the teres major muscle is very distinct in that it runs quite transversely across your field when you're doing the exposure. And that's a key landmark. If you come superior or proximal, so again, the position of the arm, distal is top of the screen, proximal is bottom of the screen. So the arm is draped across the body like I showed in the initial picture. So the position of the arm is like this. you'll see that the teres major is, if you go just proximal to it, you'll fall into the quadrangular space. And if you go just distal to it, you'll fall into the triangular interval. So for the quadrangular space, that's where our axillary nerve is going to emerge. Very, very proximally in that space, we're going to see the branch to the teres minor come off. And then the axillary nerve will split into its two main divisions, an anterior and a posterior division, that'll all be clustered together. The anterior division tends to be deeper. It is typically more difficult to find. The posterior division is sitting over the top of the anterior division typically. And the superior lateral cutaneous nerve, or that cutaneous branch of the axillary nerve, will lead you to the posterior division. If you then slide along the teres major, you'll fall into the triangular interval. And if you remember from the diagrams, the branches to the triceps come off very proximally. So you have to work pretty hard back into that triangular interval, especially if you want to find the branches to the long head and the lateral head. I don't have them in this picture. I'll show them to you in another picture from the OR. But the branch to the medial head will run along the surface of the radial nerve. So this is the main trunk of the radial nerve here. And running along its surface as a separate individual small nerve is the branch to the medial head. So this is my preferred nerve transfer donor when I'm going to try to do a nerve transfer to the axillary nerve, because it has a longer course. So the length is easier to get back to the quadrangular space. But any of the branches to the triceps can be used, and they all have various pros and cons, which we can also get into if we want to. But the main pro of the medial head branch is its length. It makes it quite easy if you dissect along the medial head of the triceps to flip it back to get it to the quadrangular space. So in a little higher magged up view, this is that same exposure with the now superior lateral cutaneous. I have this picture actually flipped. I'm not sure why, but this is the same patient. So this is that cutaneous branch that's leading you down into the quadrangular space, the teres major coming across, and then that same orientation of the radial nerve coming out from under the teres major in the triangular interval with that medial head branch sitting right on its surface. So at the start of the dissection, this medial head branch will look like it is very adherent or almost part of the radial nerve. If you do just a little bit of dissection right on the surface of the radial nerve, that branch comes off very distinctly and very easily. And so that's the giveaway that is really the branch to the medial head of the triceps. And then you can use intraoperative stimulation if you want to be able to confirm that. So now this is a different patient. So very similar anatomy. You have that teres major coming across, but now I've dissected in this patient a little bit more proximally. And you can
Só uma
see
coisa, depois,
that
lembra
branch
outra
coming
vez?
off.
Eu continuo, toda vez eu não consigo.
I think I took care of that. Yep, okay. Let me just see if, was that a question? Sorry.
No, we don't have a question yet.
Okay, I'm going to keep going then. Okay, interrupt if that was intended to be a question. So I've dissected a little bit more proximally now along the radial nerve, and you can see these are the branches that are now running to the long head. There is a branch right here that's coming to the lateral head. This is that medial head branch that's going to run along the surface of the radial nerve, and this is the main trunk of the radial nerve now coming down. So in this dissection, once you've fallen into the triangular interval, you have to start by retracting or pulling the lateral head over in order to get this exposure. If you want to keep working this down, then you have to continue the dissection or splitting off the lateral head from the long head to be able to continuously work the lateral head away so that you can continue to follow the course of the radial nerve down the arm. If you really want to get distal, you eventually have to get onto the other side of the lateral head of the triceps. It's pretty rare in most of the typical surgical exposures to need to do that. My typical exposure is to stay on this side of the lateral head of the triceps and just continuing to work by retracting it. But if you really have to get distal along it, you eventually have to get onto the other side of the lateral head to be able to get that exposure. Let's see. So another patient where now instead of having done more dissection along the radial nerve, I've done more dissection along the axillary nerve. So this can also become relevant, again, for some of the spinal cord injury nerve transfers that we do, but also in some cases where there may be parts of the axillary nerve that are recovering and parts that are not. So this is the typical anatomy now of the axillary nerve deeper in the quadrangular space. This first branch that's coming off is the branch to the teres minor. The next branch down, which is more superficial, is the posterior deltoid or posterior division. And then this deeper branch, which was at the initial exposure underneath this posterior branch, is the anterior division, which is typically going to innervate the anterior deltoid and most of the middle deltoid. And you can selectively neurotize these through nerve transfers. For example, if the anterior division is selectively injured, then you can use your triceps branch to flip back and selectively target the anterior division as a donor, as an example. Or the converse of that can be done. So we now in spinal cord injury patients will use either this teres minor branch or the posterior division of the axillary nerve as the donor. And transfer that to one of the triceps branches in order to try to restore triceps function, particularly at C6 or C7 spinal cord injuries. So that's the relevant anatomy up near the triangular interval. If I pause for just a second, are there any questions about that anatomy up there?
No questions.
We can certainly take them at the end. That's fine. Okay, so we're going to keep moving down the arm. So now we're going to get to the anatomy of the nerve around the spiral groove and in the distal arm. So it's important to understand the triceps anatomy and the names of each of the heads of the triceps to understand the anatomy that you'll see during these exposures. So the triceps long head and the triceps lateral head, as you view them from posteriorly, sit more superficial. You essentially have to cut or retract the lateral head of the triceps in order to see the medial head. And if you remember, those two branches to the long and lateral head occur very, very proximally. And then the medial head branch is going to run with the radial nerve as it comes down. As the nerve emerges from the triangular interval, it's going to course underneath or deep to, from a posterior view, the lateral head of the triceps, and then sit on the surface of the medial head of the triceps as it emerges. Where we might use this type of an exposure that we're going to go through next is for radial nerve injuries at the spiral groove. So again, that common pattern that we see with humerus fractures. Any radial nerve tumors that might be anywhere from the triangular interval, from the spiral groove down to the level of the elbow. And in rare cases, compression of the radial nerve at the spiral groove. That's a relatively debated phenomenon, whether that occurs or how often it occurs. But I do think you see it occasionally, especially in the context of trauma that hasn't injured the nerve, but may have compressed the nerve. And we'll go through what the compressive structure is. So this is the typical exposure that would be used to expose the nerve at the spiral groove. So this incision is planned to be between the brachioradialis and the brachialis muscle. That's the two key muscles that are going to show us a nice plane down to the radial nerve. So when we start that exposure, you will very frequently see some of the cutaneous branches of the radial nerve running across your field in the subcutaneous tissue. It's important to try to save as many of those as possible, especially for pain reasons. So this, I think, is a relatively common pain generator, especially if we're doing a radial nerve decompression where the radial nerve is working. And these branches are working as opposed to being part of the injury pattern. These are important cutaneous branches to try to preserve so that we don't cause pain in this area. Once we do that exposure, if we find the area where the interval between the brachioradialis and the brachialis is at, there'll be some wispy connective tissue that'll be overlying that plane that is very easy to dissect. This is essentially a finger dissection. This is one example of where the dissection is either easy or you're in the wrong spot. If you find that you're struggling, you're getting into muscle, you're just not in the right spot. This is a very truly well-developed plane that is very easy to dissect if you're in the right spot. So usually when I get to this kind of an exposure where there's this wispy little connective tissue, I will finger dissect this away, and then that'll expose you down to the radial nerve. Again, it's easy or it's wrong. So in this case, this is now that cutaneous branch of the radial nerve that is exposed here that we've preserved. And then this is the main trunk of the radial nerve between the brachialis above in this picture and the brachioradialis below. As we follow that back proximally and start to dissect along the radial nerve, you will then see that the radial nerve will dive deep to this fibrous structure. This is the lateral intermuscular septum. So this is the compressive structure if there's going to be a radial nerve compression in this area. And the lateral intermuscular septum then has to be released if you want to complete the decompression or even to get the exposure of the more proximal radial nerve, which is typically where the injury is going to be at, proximal to this area where the exposure is at initially. So as you follow that back, for the purposes of a decompression, I tend to put a longitudinal cut in the lateral intermuscular septum and then several radial cuts into it so that the septum really goes slack and is no longer compressing the radial nerve. If you're simply trying to get an exposure of the radial nerve, typically a longitudinal cut into this lateral intermuscular septum will be enough. And so as you get the exposure going proximally, once you've divided the intermuscular septum, you can follow this quite proximally along the nerve all the way back to essentially where it's emerging from around, coming around the humerus, to course along the spiral groove. Again, as you go more proximally, you will see additional cutaneous branches. These are the posterior brachiocutaneous branches, or posterior cutaneous nerve of the arm. And we want to try to preserve those as best we can. There typically is several major branches and then several smaller branches as well. And we, again, preserve as many of those as possible. You can find interesting things sometimes. This is an interesting case of a glass shard that was impaling this radial nerve, this poor radial nerve, fairly distally. And then, this is, again, an example of where the humerus fracture, unfortunately, wasn't the fracture itself, but an iatrogenic injury to the radial nerve along the spiral groove. So this is the typical exposure that we would use if we want to be able to repair the radial nerve in association with humerus fractures, or, again, any tumors that might be basically from where the nerve comes around the humerus to the level of the elbow. So I think that's that anatomy. I'll pause maybe for just a second. Any questions about any of that anatomy?
No question so far, but maybe I have a question.
Sure.
If you want to expose the radial nerve at the humerus because you have an injury and there's a complete deficit, do you go directly for the humerus, or do you sometimes use the exposure at the spiral groove and to go up?
Yeah, so my typical approach to it is always to start distal and to find the nerve in that location. So to split the brachioradialis and brachialis, as I've done in these pictures, and start distal and then expose back proximal. The operation for injuries around humerus fractures are very messy in my experience. You don't know if it's going to be in the scar, you don't know if it's going to be in the bone fracture or a bone callus or under the plate. And so my experience is if you try to go down directly onto where you think the injury is at, you may just never find the nerve. The nerve may be hidden from you by bony overgrowth, by the plate, by a whole variety of other things. And so I try to work from known normal into the space where it is abnormal. So I will typically start with my distal exposure and then do this same dissection going proximally. And it will eventually lead you to where the injury is at. So, for example, in this case where the nerve was under the plate, I would have been approaching this from screen left to screen right. following this nerve until I saw it dive under the plate. And then I will continue to expose along whatever the injury is, whether that's bony callus, scar, fracture, continuing to dissect along that until I can then find the normal nerve on the other side. If that proves difficult, you can go all the way back up to the triangular interval if you have to, and do that exposure, and then follow it going distally. That's the one scenario where you might have to get onto the other side of the lateral head of the triceps that I mentioned. So if you really have to follow that then down, you can go all the way back to the triangular interval if you have to find normal anatomy back on that side as well. And then you can work in both directions to figure out where the injury is at. But I have stopped trying to come directly down onto the injury or directly down onto the humerus because I find it too messy to actually figure out the anatomy.
Well, thank you. I think that those are very important points.
Okay, we'll keep moving along. We're going to keep moving distal. So the next is the forearm, and predominantly this involves the posterior interosseous nerve. So the posterior interosseous nerve is going to emerge then, or the radial nerve as it comes down is going to emerge from between the brachialis and the brachioradialis. And as it gets just distal to the elbow, or right at the level of the elbow, it starts to give off its two major branches, which are the superficial radial nerve, the sensory branch, and the posterior interosseous nerve, which is predominantly the motor branch. You will notice that there are several branches that are proximal to that. And this is, I will say, variably represented in different diagrams. And I will say that's probably because it's variably represented in the operating room when you see it. Where the origin of the supinator branches are at relative to where the superficial radial nerve comes off is a little bit variable. But I think most of the time, the supinator branches are actually branches of the posterior interosseous nerve as opposed to the main trunk of the radial nerve. Whereas the extensor carpi radialis brevis branch tends to be essentially a trifurcation. I think it tends to come off right where the posterior interosseous nerve is actually originating. But the important point is that the branch to the extensor carpi radialis longus is proximal to this. So it's not represented in this diagram because it's actually originated already in this deeper space proximal to the elbow. So for a posterior interosseous injury or any injury that occurs to the nerve in this area, the extensor carpi radialis longus will be preserved. That is the reason why we see preservation of wrist extension with posterior interosseous nerve injuries. As the nerve then comes down, the superficial radial nerve, as the name implies, is going to stay more superficial. It's going to course underneath the brachioradialis, between the brachioradialis and the extensor carpi radialis longus. And then the posterior interosseous nerve is going to dive deep to the supinator. And so we'll see that anatomy in a little more detail here in a second. The other nerve that I want to point out, which is sort of relevant to this exposure, is that the distal branch of the musculocutaneous nerve, which is the lateral antebrachiocutaneous nerve, is also going to come across here and sit in the superficial tissues that are going to be around the area where you're doing your exposure. So again, for pain reasons, we want to be aware that that is there so that we try not to injure that during the exposures of the either distal radial nerve or proximal posterior cutaneous nerve, posterior interosseous nerve. So when might we use this? Well, there's two different approaches to get to the posterior interosseous nerve. There may be others, but these are the kind of two workhorse approaches. The lateral approach, which we'll go through, I tend to use this for posterior interosseous nerve decompressions. I like to use this if I'm doing only a supinator to posterior interosseous nerve transfer without any other nerve transfers in combination. And then this can be a reasonable approach also for posterior interosseous nerve tumors or ganglion cysts that might be compressive in the area that you might encounter occasionally. The alternative approach is to come volar. And what we're going to see is that the key muscle here is the brachioradialis. It depends on if you're working lateral to the brachioradialis or anterior or medial to the brachioradialis. That will give you one of these two approaches. The volar approach is a little more difficult, in my opinion. And I think I only use that as a supinator to posterior interosseous nerve transfer if I'm combining that with some other nerve transfer. So, for example, if I need to use something with the median nerve where I want to expose the median nerve at the same time, then I might use this volar approach to be able to do it in a single exposure. This is also the approach to do the opposite, where you want to use median nerve branches as the donors and transfer those to radial nerve branches for radial nerve injuries. We want to expose both the median and the radial nerve in that circumstance, and so a volar approach allows that. And then for anterior neurosseous nerve injuries, one of the common nerve transfers is to use the extensor carpi radialis brevis branch as the donor and the anterior neurosseous nerve as the recipient. So again, we need both the radial and the median nerve exposed. So that's the common theme that you'll see here, is that if you need both the radial nerve and the median nerve, then I use a volar approach for that. So we're going to start with the lateral approach, and this would be the typical exposure or the typical incision that I would use for the lateral approach. So if they have a working radial nerve, then I will try to mark this out in the preoperative area, where I will have them activate their brachioradialis and try to mark the interval between the brachioradialis, which is going to sit here, and then the extensor carpi radialis longus is the next muscle back. That's the key interval that we're looking for. If you don't have a working radial nerve, then roughly speaking, you can identify the brachioradialis, and that's the muscular planes that we're going to be looking for, but you have to guesstimate your incision a little bit more if the radial nerve is not working. So here's the initial exposure. If you make the skin incision and you're in the right place, you will find that the posterior cutaneous nerve of the forearm, or posterior antebrachiocutaneous nerve, is sitting right where you're going to try to go. So it basically maps out your exposure for you, but you want to identify that in the subcutaneous tissues and preserve it. The other thing that will give you a little bit of a clue of where you're going to go is that the extensor carpi radialis longus fascia is a little bit thicker than the fascia that is over the brachioradialis. So it tends to look a little bit whiter, whereas the brachioradialis looks a little bit more translucent and so redder in appearance. So where this kind of red to white transition occurs, and essentially exactly where the posterior antebrachiocutaneous nerve is running, that's going to be the plane between your two muscles. That's our target. So when we open up that fascial covering, this is the second example of it's easy or it's wrong. This is a finger dissection. You can split this plane very easily. If it's not going easy, you're off somewhere. You're one muscle off. You're either in the muscle or you're just not quite in the right spot. So if you're struggling, it means just regroup, take your retractors out, restart the dissection, and find the place where the plane is easy. So if you split this with your finger, you'll then come down and you'll see several crossing blood vessels typically in this location. Small veins, oftentimes they have a small artery running with them. These can be bipolar coagulated and divided or clip ligated and divided to allow you to then continue this dissection down. And within this fatty tissue, it's a little bit hard to see within this picture, but you'll start to be able to make out that there'll be a superficial nerve sitting here, and that's going to be the superficial radial nerve. That'll be the first thing that you'll see. So that'll be this once you've done the exposure. If you follow the superficial radial nerve back proximally and then work one layer more towards the posterior arm or towards the extensor carpi radialis longus side of things, you'll then find this branch, which is the branch to the extensor carpi radialis brevis. And then if you keep working proximal and posterior, you then find the posterior neurosseous nerve. So from a size standpoint, my experience has been that it is roughly, the extensor carpi radialis brevis is the smallest of the three nerves that you'll see here. Typically, it's about a half of the size of the superficial radial nerve. And then the superficial radial nerve is about half the size of the posterior neurosseous nerve. So you can use the size as a rough guide of kind of which nerve you're dealing with if you happen to think you fell on to the wrong nerve during your exposure. But this exposure occurs basically going from superficial and anterior to deep and posterior. You'll find superficial radial, extensor carpi radialis brevis, and then posterior neurosseous. As we expose this further, you can get the superficial radial nerve very nicely exposed. There's nothing that's going to be compressive of that. This is the brachioradialis being pulled out of the way to get this exposure. The extensor carpi radialis brevis is then going to come down and innervate the muscle. And as the posterior interosseous nerve comes more distally, it's going to dive underneath the tendinous edge of first the extensor carpi radialis brevis. You actually have to move a part of the tendon of the ECRB before you'll see the supinator. The supinator and its fascial edge, which is called the arcade of Froge, is the theoretical compressive spot for a posterior interosseous nerve decompression. And again, that's also a debated topic about how often or whether that occurs. But if there is compression of the posterior interosseous nerve, that's where it tends to occur, is at the leading edge, which is a fibrous fascial edge of the supinator muscle. Once you've moved the extensor carpi radialis brevis out of the way and it opened up the supinator, you can then follow the posterior interosseous nerve down the forearm to complete your decompression. So again, the anatomy here is posterior interosseous nerve, extensor carpi radialis brevis with its two smaller branches in this case, and then the posterior interosseous nerve tracking down the forearm. If you follow the posterior interosseous nerve more proximally, now this is a different patient. So this is the posterior interosseous nerve here in the picture. If you follow it proximally and then dissect along each side of that nerve, you will eventually encounter a branch that comes off each side that is going to the supinator. So there typically are two supinator branches, one on either side of the posterior interosseous nerve, and you can follow those down into the substance of the supinator. If those are working branches, which they usually are, if that's why you're trying to find them, because they're good donor branches, you can also use your nerve stimulator in this case to stimulate around in this area and locate where the nerve branches are at. But there will typically be one branch that's going to the superficial head of the supinator and one branch that's going to the deep head of the supinator. And again, they're typically arranged on either side of the posterior interosseous nerve itself. So this would be a common nerve transfer that can be used, especially in spinal cord injuries, but I've used this in Parsonage-Turner syndrome patients, where you might use these supinator branches as the donor and the posterior interosseous nerve as the recipient. What you have to be careful when you're doing is when you make the cut in the posterior interosseous nerve, you have to be careful not to disconnect your supinator branches at the same time. So you want to dissect along those supinator branches and peel them away with an intraneural dissection away from the posterior interosseous nerve so that you can make a proximal cut on the posterior interosseous nerve and then make a very distal cut on the supinator branches with leaving them with their preserved connection proximally. This is the other branch that can be used as a donor, which is that ECRB branch. In this exposure, I typically don't use this as a donor for any purpose, but we're going to see when we take the volar approach, this is going to be one of the workhorse donors for nerve transfers. So I think that's the relevant anatomy for, and this is then that nerve transfer. So here's the two supinator branches that have now been cut distally. This is the posterior interosseous nerve that's been cut proximally, and you can bring these two supinator branches together for the nerve transfer. So that's the lateral approach. Now, how about the volar approach? So we're going to see very similar anatomy. It's important to remember that that anatomy is still true, even if you're seeing it from the other side. So we're just going to see this now from the other side of the brachioradialis. So this is the incision that I would typically use. So I like to make an S-shaped incision. The biceps tendon is the target for where I like to start the proximal aspect of this incision. I then bring it to the edge of the brachioradialis and then a lazy S down the forearm. So this is what the initial exposure will look like if you start distally. So we've made a skin incision, I've opened the fascia, and now distally, running along the edge of the brachioradialis, you'll encounter the radial vessels. That's what's in the red vessel loop, and the superficial radial nerve. So that is those are going to be key landmarks, because what we want to be able to find is this structure, which is the pronator teres tendon. So if you find the superficial radial nerve and you find the radial vessels and you go right between them, that will take you to the pronator teres tendon. If you're not going to be doing something where you want to use the pronator teres as a tendon transfer, then what I like to do is put a step lengthening cut into the pronator teres tendon, because it helps you expose the median nerve proximally. So if you put a little cut into the tendon, along the tendon, and then out of the tendon, it'll let the tendon itself pull apart a little bit or lengthen, and that loosens the tissue around the median nerve proximally to allow you to get the better exposure. So the key anatomy here is work between the superficial radial nerve and the radial vessels to find that. And then as we go proximal, we're going to work on the other side of the radial vessels, pushing the radial vessels off of the flexor pronator mass. So this mass of muscles is the flexor pronator mass. And as we work proximally, we're then going to work off the edge of the muscle. The radial vessels have now been pushed away. And now this is the median nerve at the depths of that proximal exposure. As the median nerve comes distally, it'll run under this arch. That's the arch of the flexor digitorum superficialis. That's theoretically where the median nerve can be compressed in the forearm. And we can divide that fibrous arch to get further distal exposure of the median nerve, which is what we're going to do here in just a second. Again, this is a little closer picture of that fibrous arch. You can scooch the muscle. You can kind of strip the muscle off of this fibrous arch and divide just the arch without needing to cut any of the muscle fibers themselves. So this is the exposure you'll get if you do that. So this is your median nerve now that we've exposed going more distally. We're going to come back now and talk about the radial nerve, since that's the focus of this talk. So the superficial radial nerve is what we exposed here initially. The radial vessels are in this red vessel loop. If we work along the superficial radial nerve proximal, it'll take us back to now this branch, which is the next one over, is the extensor carpi radialis brevis branch. If we follow that back further, you'll eventually see where these will come together and the posterior interosseous nerve will come off right here. I don't expose that actually during this, this set of operative pictures, but the posterior interosseous nerve would be right here coming off to dive under the supinator. So this muscle is the brachioradialis. So in the lateral approach, we're working on the other side of the brachioradialis and seeing this from the opposite angle, as opposed to if you come from this angle, you're now working underneath the brachioradialis to see the relevant anatomy. On the median side of things, again, a common target would be the anterior interosseous nerve as a donor, as a recipient. So for anterior interosseous nerve injuries, one of the common nerve transfers will be extensor carpi radialis brevis branch of the radial nerve to the anterior interosseous nerve. The anterior interosseous nerve on the median nerve is going to come off of the deep radial side. It's the only branch that comes off the radial side of the median nerve. So on that side, you can find anterior interosseous nerve. If you needed to find median branches to use as donors for radial nerve injuries, they all come off of the ulnar side. And going from proximal to distal, they tend to go pronator teres branch very proximal, and FCR branch, which will be next. FDS branch comes next, and then there's typically a second FDS branch that is running kind of along with the median nerve in this location. And so the FCR, FDS branches are good donors for radial nerve injuries, especially very proximal radial nerve injuries that you can't directly repair. Those branches can be used as donors to target wrist extension through this ECRB branch as a recipient, and finger extension through the posterior interosseous nerve as a recipient. So this is what the nerve transfer targeting the anterior interosseous nerve looks like. So we've dissected this anterior interosseous nerve away from the median nerve, and we've taken the extensor carpi radialis brevis branch as the donor for that nerve transfer. I think that's the relevant anatomy now in the forearm. Did we have any questions about any of that?
Well, the audience is quiet in awe.
Okay.
so maybe a question from my side.
Okay.
Just as we come to the next region. Personally, I think the PIN anatomy is quite challenging, especially in the phase of trauma, and so my question would be if you still reconstruct the PIN, and what are your major landmarks you would be using if you you would have to find the distal branches. So let's say you want to do reconstruction, you have the proximal PIN branch, and then there is a mess, there's scar, and you look for the distal branches. What is your strategy in short?
Yeah, that proves very challenging, at least in my experience. You know, the few of those that so in the setting of a clean laceration where you're going in early to try to do it, that's relatively straightforward. You know, that you can usually find, but in a more delayed attempt at a repair, it's extremely challenging. You know, the truth is I don't have a lot of great tips for that. It proves very, very hard. So I think, you know, you have to understand what your main targets are that you're trying to get out of the repair. So the main targets typically with a traumatic injury to the posterior interosseous nerve is you really want to try to get finger extension back. And so what I will typically do is actually to dissect distally in this same plane. If you keep going along the so I would expose the posterior interosseous nerve proximally. And I tend to use the lateral approach if for this purpose. I find that a little bit easier compared to the volar approach. So if we go back to that posterior approach, I tend to expose the PIN very proximally at the elbow and then try to follow it down and see if just simply following the nerve down will let me figure out where the injury is at. But many, many times somewhere in this region, it's cut, destroyed, you know, that's where the injury's at. That's where all the scar tissue at. It's a big mess. So then you have to use your muscular anatomy. And again, that's where understanding where the muscles are living at is important. So this muscle here is the extensor carpi radialis brevis, brachioradialis, and then the other muscle that we've pulled up out of the way here is the extensor carpi radialis longus. All of those need to get moved. So you have to individually identify those muscles, because if you're still working in those muscles, you're not in the right plane. The posterior interosseous nerve and its branches are deep to all of those. And so I try to figure out where the plane is between the ECRB, ECRL, and then now the deeper muscles. If you keep pulling the ECRB away, the next muscle down that you will see will be the extensor digitorum. And the extensor digitorum, if you can find its surface, I then try to work along its surface to see if I can find the main motor point of the posterior interosseous nerve branch that's going into that, and use that then to work backwards. So if you work along the surface of, or can identify the identity of each of the muscles, that can give you a clue to be able to find the motor point of that individual muscle, find the branch of the nerve, and then work along it. That's the best tip I've got. It's not a great tip because it's messy. It's really hard. What I tend to do is if I can't find the extensor digitorum branch, then I don't think the reconstruction is going to be very successful. Oftentimes that means that you're not going to get much out of it. It's probably actually better to just have them get tendon transfers to try to achieve that function.
Okay. Well, thank you very much. Would you combine lateral and volar approach?
You certainly can. Yeah, I mean, I think I've only done that in one operation, which was a trauma case. But you know, usually, I guess, under what circumstance were you thinking, Thomas?
Just devastating injury, and you want, for example, you want to identify the distal muscle groups, for example, extensor digitorum, and just to be sure you still have a muscle, or
Yep. So that's the one circumstance that I did it in. It was in a really, really complicated injury, and I felt like I wanted to see it from two different angles to see if I could figure out where the distal aspect of the nerve was at. In most cases, I think you can figure out the anatomy from either approach. I don't think either is wrong. I just find the lateral approach a little bit more straightforward in most cases, but I think probably the more common approach is actually the volar approach. I think that's what most people teach. But so I don't think either is wrong per se. And you do get a different view. You get a different angle. Sometimes you get into better tissue planes if you come from one versus the other. And so if you're struggling, I don't think it's unreasonable to go to the other approach and see if it leads you in a better direction, especially in these complicated trauma cases.
Perfect. Thank you.
Okay, well, we're going to go to the last region. So that's now we're going to get beyond where the motor branches are at and think about the superficial radial nerve down at the level of the wrist. So the operations where we might think about using this kind of an approach would be a superficial radial nerve decompression, superficial radial nerve biopsy. We're now occasionally doing sensory nerve transfers, so using the superficial radial nerve as a donor, typically to median nerve, to try to restore sensation in the median territory, or a superficial radial nerve tumor. So again, similar kind of lateral approach, but now we're going to can think about that as the continuation as you go distally. So again, the two relevant muscles here are the brachioradialis and the extensor carpi radialis longus. So if you make the incision down here kind of distally along the wrist, so kind of from where this hash is at going distally, this is what the exposure will look like. So the first thing that you're going to see is the very distal aspect of the lateral antebrachiocutaneous nerve. It's basically in the subcutaneous tissues. And so this is another nerve that you want to be careful to avoid injuring, mostly for pain reasons. I mean, patients will tolerate the numbness of that quite well, but if you injure this nerve and cause them new nerve pain, that's a big problem. So recognize that that's going to be in the subcutaneous tissues. The other reason that that's important to know is if you're trying to target the superficial radial nerve for the biopsy, don't get confused and think that this is your biopsy target. That's a common mistake that I see at least my trainees make, is that they dissect down, they find this nerve and think that's what we're biopsying. But in fact, that's the lateral antebrachiocutaneous nerve, and you've got to get down to the level of the tendons before you start to see the superficial radial nerve. So when you come down, I've got this label now on the picture. So BR is brachioradialis. This is going to be the brachioradialis side. So this is the tendon of the brachioradialis. And then on the other side, you'll see the tendon of the extensor carpi radialis longus. What the superficial radial nerve is typically going to do is emerge from a sort of a triangular point between those two tendons. This is an unusual case of a superficial radial nerve compressive syndrome, where the superficial radial nerve was actually piercing through the brachioradialis tendon. And I've actually seen that in, I think, 3 cases now. So it's a little bit unusual, but you actually may encounter this in a patient that's having superficial radial nerve pain. So this is a little bit of an unusual example, but more typically where the nerve would be right here, where that little bit of fat is sitting. So between this brachioradialis tendon and the extensor carpi radialis longus tendon. So if you're doing a biopsy, you simply just need to expose this and do your biopsy. If the point of this is actually to do a decompression, then in this case, we had to open up the brachioradialis tendon, but that is a tenotomy of the brachioradialis tendon is what will typically get you the decompression. So if you've done a little tenotomy of the brachioradialis tendon, preserving about half of the tendon and its insertion point, the brachioradialis is still functional, but now you've created a much bigger space where the superficial radial nerve can run through. And if we followed this back, if you remember, the lateral approach is exactly between these two muscles. So these are the two key muscles when you're thinking about radial nerve anatomy and a lateral approach, is that ECRL and brachioradialis. And this now is the continuation of the sensory branch that emerges from between the two of them. That's a much shorter section because it's quite clean anatomy with not much else in that area. So that brings me to the end of the talk. I would gladly take any questions, or if there's any discussion. This is my email address for any of the attendees. If there's anybody that wants to ask me questions in that way, you can feel free to email me. Or if there are cases, things you want to talk about, I'm always happy to chat about these things.
Well, Thomas, that was excellent. Thank you very much for this perforce tour through not only the radial nerve anatomy, but the of course surgically relevant anatomy and points. Those were excellent pictures already here. Thank you to the audience as well. We had almost no drop, so that's a good sign. So this is your chance. If you still have questions in the chat or in the questions and answers section, we still have a little time to go through these, and If not, I would like to ask you another question. What is the most frequent injury you have with the radial nerve you have to deal with?
Yeah, I mean, I think certainly the most common injury pattern that you see for an evaluation will be radial nerve injuries in association with humerus fractures, at least in my practice. The good news is many of those just get better on their own. You know, the data says that the majority of those will get better. But that's certainly the most common that I evaluate. I think that that's also for a radial nerve injury. That's probably the most common thing that that I operate on as well. It's probably not the most common thing that I do with the radial nerve, meaning that I do a fair number of radial nerve to axillary transfers for brachial plexus injuries. So that's probably the most common radial nerve surgery that I do. But for radial nerve injuries, it's probably that mid shaft of the humerus fracture associated injuries to the radial nerve, which then can either be, again, the injury associated with the fracture, or unfortunately, I see a decent number of iatrogenic injuries where the nerve is plated, unfortunately.
Okay, so and we have a question from the audience. So I take from this you still do a fair amount of nerve reconstruction also.
Oh, I do. Yeah, absolutely. There, you know, I didn't say this anywhere in the talk, but you know, I for reasons that I think, I don't know, maybe you've got a better idea of why this is, but out of all the nerves you can injure in the body, the radial nerve wants to recover. It's, you know, it's certainly one of the most rewarding nerves for reconstruction purposes. You can have very proximal injuries to the radial nerve with pretty long gaps. And if you reconstruct it, you oftentimes get pretty good outcomes. So I'm pretty aggressive about reconstructing the radial nerve as opposed to going straight to nerve transfers or tendon transfers. I think, you know, if you can find the ends of the radial nerve, you should essentially always try to reconstruct it, I think.
Okay, with this, you already answered the first question we had from Saurabh Singha. I'm sorry if I'm mispronouncing. And first of all, he congratulates for this excellent talk. And he was asking what is the success rate of nerve transfer in re-establishing function?
So if we're talking about nerve transfers for radial nerve, so I'll answer that in a few different parts. So nerve transfers for, say, a proximal radial nerve injury, where we're going to use median nerve branches as the donors and radial nerve branches as the recipients. So the common thing would be FCR to PIN and FDS to ECRB. I think those are newer. We don't have a lot of great data on that yet, honestly. And the relearning that goes along with that, so the cortical plasticity and the relearning that's needed to actually make that work is a little tricky for patients. It's not the most intuitive nerve transfer. So I think the reinnervation that occurs is probably similar to all of our other nerve transfers. You know, I would guess 70–80% success rate of reinnervating the muscles through that. But the relearning is more difficult. And so the functional success of it, I think, is a little lower. It's probably one of the more complicated nerve transfers to learn. So I typically quote people 50–60%, something like that, chance that it'll be a functioning, useful nerve transfer.
And I would like to make a point for nerve reconstruction with the radial nerve, because we know it's one of the best nerves to reconstruct if it's for example at the humerus level. So you can get your thumb up, you can get your fingers up again, and so we should not forget about the graft reconstruction, especially for that nerve. We have another question.
Sorry, can I make one more comment on that, actually? Is that
sure?
So I think, you know, I just want to make sure that's what they were actually asking. So as opposed to, we do nerve transfers to the posterior neuroosseous nerve, as an example. So the most common nerve transfer to posterior neuroosseous nerve, say in the setting of a spinal cord injury, or I use this nerve transfer sometimes in Parsonage-Turner syndrome, supinator to PIN, that nerve transfer works beautifully. It is a very successful nerve transfer, very intuitive for people to learn. I mean, it works in almost everybody. It's a fantastic nerve transfer. But it's only in a very select few patients that you can do that in. It's, that's the supinator branches are part of the injury pattern for a radial nerve injury. So you can't use that as a donor. So it's in the spinal cord injury patients, Parsonage-Turner syndrome, a few select other cases, but that's a beautiful nerve transfer.
And I think you already made that point during your talk. It's a good solution in some of these brutal Parsonage-Turner cases. So next question probably already covered by Nadim Akhtar. Injury at radial groove, does it recover good?
So number one, as long as it wasn't, lacerated, as long as it wasn't plated by your orthopedic colleagues and, inadvertently, if it's really just a stretch injury related to the fracture, that actually has a very high rate of spontaneous recovery. But then if you take that one step further and say the ones that aren't recovering, if you have to reconstruct those, it also recovers beautifully. There's no nerve that is more rewarding to reconstruct, in my opinion, than the radial nerve. It works quite well. And the functional loss that they have that you can get them back is extremely significant in their life. So I'm a huge advocate for reconstructing the radial nerve when you need to, as opposed to doing, again, tendon transfers or nerve transfers. Unless the injury is way up in the axilla, I would always reconstruct the nerve. And even that's debatable. I think even a very, very proximal radial injury, you still have a reasonable chance of getting function back, actually. So yes, it recovers very well. Radial nerves, it gets an A+ for me for reconstructing.
How long would you follow up if you're pretty sure that the nerve is not severed and still the loss is complete? How long would you wait, and what would you use to monitor the progress or potential progress?
Yeah, so this is where understanding that branching pattern is key. The brachioradialis is the first branch of the first muscular branch after where the injury typically occurs. So that's your key muscle for understanding whether there is early recovery. So I use both clinical examination and electrodiagnostics, and the brachioradialis is really the key. I tend to give them 6 months. If they're not showing signs of reinnervation at 6 months, then I'll do the reconstruction. The injury pattern, though, and the story that the patient gives you is really critical for me. So if the patient says that they're really sure that right after the injury, right after their trauma, they couldn't, extend their wrist or extend their fingers, as opposed to they went into the surgery being able to do it, and they came out of the surgery not being able to do it. I treat those very differently. The patient that has the injury from the time of their trauma, that's who I will give 6 months. I will image them typically and make sure that I don't see a lacerated nerve. Usually your orthopedic colleagues have said they see the radial nerve during their operation and can confirm for you whether or not it's lacerated or not. Not always, but sometimes. So if that's not confirmed, I will image them with either ultrasound or MRI, typically ultrasound. And if you don't think it's lacerated, then I give them that 6 months. Now, if the story, though, is that they went into the surgery not having good function and came out of it not having function, I think you have to suspect that the radial nerve is badly injured. I would explore them right away.
So thank you very much for that. I'm just checking again on the chat. I'm not sure if that is a question. That is again from Nadim Akhtar. Radial nerve injury due to injection recover well. So I'm not sure if this is a statement or a question, but maybe you want to respond.
Yeah, I will say actually, maybe I'll make 2 comments on that. I think that yes, it recovers well. It's, my experience has been that injection injuries, just generally speaking, recover pretty well for the most part. But the radial nerve in particular, just like any other injury, for whatever reason, the radial nerve wants to recover. I think the exception to that is I've actually seen some quite bad pain syndromes where it is a superficial radial nerve injury related to an injection, and complex regional pain syndrome develop afterwards, and very bad pain syndromes. And for whatever reason, this is also a well-known phenomenon that the superficial radial nerve is very prone to pain. So if you do, a biopsy of the sural nerve, for example, compared to a biopsy of the superficial radial nerve, you're way more likely to get pain with a superficial radial biopsy compared to a sural nerve biopsy. The sural nerve, the superficial radial nerve doesn't like to be messed with, and that includes injections. So I think a true radial nerve injury does tend to do very well, just like it does with any other kind of injury, whereas a superficial radial nerve injury from an injection, which would probably be the more common thing to be injured, doesn't actually do as well.
Okay, so I think we already have 70 minutes. So let me thank you again for an excellent talk, and there's still applause for you in the chat, and also thank you to the audience, because everybody stayed. Okay, so that's quite nice. So I think we had a very enlightening and interesting session on a clinically relevant radial nerve anatomy, and I would say we conclude the session with this. Thank you very much.
Thank you all.
Hey guys,
reach out to me if I didn't get your questions answered.
okay,
thank you.
Thank you guys. Thank you, Professor Wilson and Professor Thomas Kretschner. On behalf of the World Federation of Neurological Societies and Rhoton Anatomy Committee, we thank you, appreciate your time. You spend, it's 5 a.m. in California. This is, tremendous effort, and we appreciate it. I thank you so much for your efforts and the wonderful talk and the wonderful moderation. Just remind the audience that the next Friday, so every second Friday of the month, it's going to be a skull base webinar. The first Friday of each month is going to be, peripheral nerves. And every last Friday of each month is going to be brain's anatomy. So once again, thank you guys so much for your effort and time. I thank the audience as well. Thank you so much.
Pleasure.
Bye-bye.
Bye.
Thanks, Thomas.